So welcome everyone for this final webinar, which is a very novel concept set in motion by Dr. Gautam Zaveri in this president for the 60th year of the Bombay Orthopaedic Society. It's a worldwide connection on once a month on every different topics with lots of people across the globe. And this is for the first time that we actually have a guest speaker from all the way from Brazil, Dr. Sergio Rowinsky, and our very own trauma experts, Dr. Dhaval Desai, our BS Secretary, Dr. Ashish Phadnis, Dr. Parag, Dr. Vivek Shetty, and Dr. Jayesh Baviskar on board. For those of you who don't really know much about the Bombay Orthopedic Society and are tuning in for the first time, I invite Dr. Ashish Phadnis to please give us an introduction.
Thank you, madam. Just give me a minute. It's Good afternoon, everyone, and a warm welcome to one and all for this webinar, which will be the concluding webinar of this academic year. It gives me immense pleasure to welcome you all for this webinar. And today we are focusing on trauma, upper limb trauma, and to be very specific, the challenges posed by the fractures around the humerus, shaft of the humerus. To give you a brief about the Bombay Orthopaedic Society, as we do always, Bombay Orthopaedic Society is celebrating its 60 years of excellence, 60 years of existence this year. And it is on these giants whose shoulders that we are standing, that we are growing from strength to strength. We have arrived here based on strong principles and strong academic foundations which have been laid by our founding fathers. It all began in Mumbai in 1966, and Dr. R.J. Katra, along with stalwarts like Dr. Talwalkar, Dr. Dholakia, Dr. Kini, Dr. Masalawala, founded the society where Dr. Ellen Bora was the secretary, Dr. Masalawala and Dr. Mullah Firoz were the two EC members. We went from strength to strength, and it started with bi-monthly clinical meetings and had a lecture program over 3 days. And they started holding the Western India Regional Orthopedic Conference, which became a landmark event in the orthopedic calendar every year. BOS grew from strength to strength, and over a period, we saw a good growth in our membership, good growth and faith that our members sort of interested in us in conducting these activities that we did. We also have a journal, which I'm pleased to announce that it is a DOAJ index journals. It will be indexed in the directory of open access journals, so that now we would attract more and more publications, and our members can have a home to their research and their work. We do encourage a lot of research work from our members, and our research has been cited and is clinically sort of useful research for most of the members. Where do we stand today? Today, we are directly influencing a lot of orthopedic surgeons across the country, and these webinars are sort of an endeavor or an attempt at us to reaching beyond the borders of our country and to orthopedic surgeons all across the world. So these webinars were started with the intent of sort of collaborating with different organizations. And over the last 1 year, we had 12 sort of webinars with different reputed orthopedic associations like the SICOT, the Bone and Joint Journal, the British Hip Society, the World Association of Infection and Orthopedics and Traumatology, the Pediatric Orthopedic Society of the Canadian Pediatric Orthopedic Society, where we discussed with issues regarding pediatric hip, and numerous such organizations like the British Orthopedic Sports Training Sports Trauma Association. Today, we will be discussing this topic, and this webinar will be with the AO Trauma faculty. And I would sort of invite our co-panelist, Dr. Dhaval Desai is a dear mentor and who has kindly agreed to sort of convene and coordinate this webinar with us. Dr. Dhaval Desai has been the research chair for the AO Trauma Asia Pacific, and he's the current research chair from 2023 to 2026. Previously, he has been the chair, he was the chairman and the AO Council between 2021 and 2023. He has been an AO Education Officer for AO Trauma India. He is a AO Alliance faculty and a fellow supervisor. He has been a mentor to a lot of us, and basically he is instrumental in a sort of in helping us become AO Trauma members and ascending to the ladder. And of course, a force behind propagating the values of excellent trauma care all across the country. We welcome you, sir.
Thank you.
Along with Dr. Dhaval Desai, we will have Dr. Sergio Rowinsky logging in all the way from Brazil to talk about his experiences in management of fracture of the shaft of the humerus. And I would invite Dr. Dhaval Desai to sort of introduce him. We also have Dr. Parag, our dear Executive Council member who recently conducted a very successful VIROC, who is a sort of an orthopedic hand and a microvascular surgeon who will be talking to us about the nerve injuries and issues relating nerve injuries with the fracture of the shaft of the humerus. And another senior colleague we have, Dr. Vivek Shetty, who's a consultant at Hinduja Hospital, is a very senior air trauma India member and a senior member of the Bombay Orthopaedic Society. And I would also welcome our webmasters, Dr. Gaurav Sharma, Dr. Agnivesh Tikku. I would welcome Dr. Jayesh Baviskar, who has been very sort of enthusiastic in coordinating all the webinars. And of course, the force behind these webinars, I would really like to thank Dr. Rujuta Mehta, madam, and thank you very much, ma'am, for helping us with all these webinars. And finally, Dr. Gautam Zaveri, sir, who is our president, who unfortunately can't log in live due to his internet connection, but in principle and in spirit, he is there with us right now. Thank you very much. And without wasting much time, I would invite Dr. Dhaval Desai to start the proceedings, sir.
So welcome. I take this opportunity, thank you, BOS, and I take this opportunity to introduce Dr. Sergio Rowinsky from Sao Paulo, Brazil. It's very difficult to describe Sergio in few words, but I would say that he's one of the most passionate teachers in orthopedics that I have known across more than 2 decades. He is a very dedicated upper limb surgeon, and I think the era before of internet, before the webinars, when the education happened across, the India Orth platform, he's one surgeon who probably, I would say without any hesitation, that really changed or revolutionized the minds of a lot of orthopedic surgeons in India to a technique of fixation of proximal humerus fracture, which he will share, by just sheerly passionately teaching across with case by case. There's no references, no lectures, but just case after case that we have discussed in the last, the early 2000 with him, that eventually I think most of us have been convinced to use a technique that probably developed in Latin America and is now so popular in India. So I'm very proud and happy to say that Sergio deserves the credit. He has been to India many times, probably more than 10 times, and visited 22 cities. And his passion for this technique that he moved Brazil to teach upper limb care in various parts. And then his passion for wine and the Indian Hindi language is something that he also learns to be seen. Thank you. Welcome, Sergio.
Lovely, sir. Excuse me. Is my lecture the first one, gentlemen? Yes or no?
Yes.
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 Okay. So can I speak just 1 minute and I start? Okay. Can I do it?
Yeah.
Yes, please.
Okay. So it's a pleasure to be here. I'm Dr. Sergio from Brazil. Actually, many people may know, but many people may not know. My relations with India, they last from the year 2010. So I have now 16 years of relations with India. I talk to young and older Indian orthopedic surgeons around 1 to 2, maybe 3 times a week, helping them in WhatsApp with the local cases. The last case was from happening on Friday with our good friend, Dr. Hajvir Chinoy from Mumbai. He was asking my help, and this is my life for 15 years now. I have a long history in India Ort, where from 2010 to 2018, I shared dozens and dozens and dozens of cases. And this technique particularly gained a lot of popularity in India in the last 15 years. It was not, of course, introduced by me in India. It was there, but I helped too much in the development of this technique in India, humeral anterior bridge plating, and now it's very popular, okay? And just for you to know, this technique is a technique created in the city of Campinas, 90 kilometers from São Paulo, by a worldwide known trauma orthopedic surgeon, Dr. William Dias Belangero, who is very known, and he's the pioneer of this technique. He lives 100 kilometers from São Paulo here. So this is a very nice technique. As Dr. Desai was mentioning, I have already been in India 10 times in person. I have operated 18 shoulders, being nine live shoulder arthroscopies. I'm very proud of that. But today we are not talking about arthroplasty or arthroscopy or clinics. We are talking about this technique, which I love. And I prepared a very special lecture, considering that we don't have all of the time that I think it would be needed. I would like to talk about 1 hour. Obviously, we don't have this time, but I made a summary of points that I consider relevant to give a message in the end. So we will discuss here some cases, some principles, some technical aspects, and I am Dr. Sergio from São Paulo, Brazil. So just for you to know, apart from all I have mentioned, I am a member, of course, of Brazilian Shoulder and Elbow Society. I am a member and a very active member of the Argentinian Shoulder and Elbow Society. I am a member of the Latin American Shoulder and Elbow Society, and I am a former member of SICO, Shoulder and Elbow Committee. I was a member from 2022 to 2025. So let's start talking about something interesting, the size of my incisions. A lot of people tell me, Dr. Sergio, how can you do such tiny incisions in humeral anterior bridge plating? Well, my incisions, indeed, they are very small. I'm going to tell you how to do it. And this is just a curiosity. Sometimes we can find the cephalic vein in the proximal incision and in the distal incision. I have seen this 2 or 3 times in 22 years, but let's talk now about the size of the incisions. So my proximal incision has around 4 centimeters, maybe less. I'm going to show you many cases. And my distal incisions, they have about 2.5 to 3 centimeters. They are very small. So how do I manage to do this? So how to establish the incisions in the perfect position, in my opinion? Well, to do perfect incisions, in my opinion, you have to draw the incisions. And so how do we do to properly draw our incisions? So when you start in surgery, this is the tip and this is the trick, okay? The patient is already there under anesthesia, prepared. And when I show this X-ray, we have to think about the C-arm. So imagine that when we are looking at this X-ray, actually we are looking at the C-arm, and all of this is always done under traction, which is the magical word, and always under C-arm guidance. But when we are looking to this X-ray, we are actually looking at the C-arm, okay, the CCTV. So having said that, when you reduce the fracture and you put the plate in the right position, it will be, you are looking at the C-arm. So looking at the C-arm, we are passing a line on the upper part of the plate and in between the second and the third plate and the third screw from superior to inferior. And we do the same, a line in between the inferior part of the plate and from the second to the third screw from inferior to superior. And there will be my incision, remembering this, as I have been telling my Indian friends since 2010, 15, 16 years, I always put only 2 screws, never 3 screws. So having said that, we are looking at the C-arm, the fracture is reduced, okay? So always under traction, which is a magical world, and always under C-arm control. So the fracture is reduced on C-arm, we are under traction. So I'm gonna pass that line on the tip of the plate in between the second and the third, and this is gonna be my proximal incision. And I'm gonna do the same inferiorly, and this is gonna be my distal incision. So there is no, so each incision is specific to each case. And what is the sequence of the surgery? Okay, so there is a sequence. So in the way that I have told you, we do both incisions, always under traction. So traction is a must in this technique all of the time. And it's not a redundancy. It's not a redundancy that this technique in my hands must be done with a lot of delicacy, all basically slow motion and with a lot of calm. So I have done my 2 incisions, and then we have to connect the incisions. So how to connect the incisions? I do not suggest to do it with the both index fingers of the surgeon, because the surgeon will hurt himself, because you can damage your fingers connecting, because you have to create a path below the brachialis muscle insertions in the anterior part of the humerus. So I use a delicate osteotome. I use the plate, and a nice tip is to use a longer plate with 16 holes or 14. It helps a lot. And it doesn't matter if you connect from superior to inferior or inferior to superior, but the magical word is always there. Hamesha, always there, constant traction. And then when I have done the incisions, this is important in the way I do it. I start with this hole. So I always start drilling the penultimate screw from superior to inferior on the distal perforation. This is my first perforation, and always without the plate. I do it freehand, no guide, and the plate is still not there. So this helps me having tremendous control on reduction, as I'm going to show you in a minute. So I do that per perforation, and then I introduce the plate. It doesn't matter from superior to inferior or inferior to superior. It doesn't matter, but the magical word is hamesha there, constant traction. And I put a screw, and then I put the plate, and I put a screw in that hole, but partially screw. This is very important. I grasp both corticals, and then I unscrew, and I put the tip of the screw in the middle of the intramedullary channel. This is a must, okay? And at that moment, with one screw partially screwed on the distal incision, on the penultimate hole, then I'm gonna check reduction under C-arm. I'm gonna enhance that I have a good reduction with traction, okay, which is a magical word. And then my assistant is gonna drill one upper distal hole, which I prefer to be, again, the penultimate hole and not the last one, from superior to inferior. And then I'm gonna put a screw over there, but partially screwed. So what I want to do is to have both screws partially screwed. So one superior, one inferior, both in the middle of the intramedullary channel, the screws. So I'm grasping only one screw, okay, only one cortical, and then I'm gonna adjust under C-arm control varus and valgus. So I'm gonna achieve the best possible reduction, and then we have to fix both screws, and then it's done. We just have to put one more screw up and one more screw down. So I would like to show 15 cases, but we don't have time. But I want to show 4 very, very, very pedagogical cases and then come to my conclusions. So it's important to understand that every pattern of humeral shaft fracture can be managed with this case, as long as you have space to put 2 screws up and 2 screws down. So this is a case from December 2016, 21-year-old girl, a transverse fracture, So in my hands, obviously, there is no discussion about it, anterior bridge plating. So I did it. Okay, it was after Christmas, 10 years ago, 9 years ago. This is the immediate post-op AP view. This is the lat view. It's interesting to discuss that the plate could be put a little bit more inferior. Yes, but it doesn't change the mantra. India is the land of mantras. So the mantra never changes. 2 screws up, 2 screws down, and you can do it. So we did it. So this is the AP view immediately after surgery. This is the size of the incisions on that beautiful girl I'm going to show you. So 3.5 centimeters proximally, and here 3 centimeters distally. So this is 8 weeks AP view. This is 8 weeks AP view, and it's important to make people understand that there is another mantra which is timeless. It will never change, which is innumerable anterior bridge plating, clinical healing precedes radiographical healing, which means the patient will have a clinical healing much before radiographical healing. This mantra never changes and will never change. And when you have young patients like this, callus starts to appear around 7 to 8 weeks. This is 8 weeks post-op. We are starting to see callus. This is 8 weeks post-op, a beautiful, well-taken lat X-ray lat view. And here we can see starting callus, but clinically this girl was rocking. And this is 4 months post-op. We can see a lovely callus, secondary bone healing, lovely callus in the AP. This is a lovely callus on the lat view. And from a clinical point of view, the girl was fine. She developed some keloids. This is absolutely not under our control. We have a lot of keloids in Brazil. There are reasons for that. I can explain later, but see how tiny incision distally, okay? Super small. And how is the girl from a clinical point of view, the patient? So this is the last time I saw her. Very small incisions. The elbow flexion was okay. The elbow extension was okay. Super discrete incisions. The shoulder was functioning fine. She wanted to go to the gym and everything was fine. But this is something nice. So how far can we go? And I'm going to show to you mind-blowing cases. How far can we go? And the answer is on the mantra. The mantra says 2 up, 2 down. So this is a very interesting case. A very obese lady, 23-year-old woman, but quite obese with this distal metaphysio-diaphyseal fracture, a long oblique one. And the question is always the same. Can I put 2 screws? Well, I can put 1 screw here. I can put 1 screw here. Absolutely no place for mistakes, 0 place for mistakes. This is not a case for beginners. This is a case for people who have already mastered the technique. So if there is space for 2 screws, I can do it, but we must never forget, we must check it on the lat view. So I have space for 1 screw, no place for mistakes. I have space for another screw, no place for mistakes. And it's a fallacy, it's a lie. I repeat very slowly. It's a fallacy, it's a lie that when the plate is put very distal on the humerus, you will have pain and it will bother elbow motion. It doesn't exist. I'm going to prove it to you. I'm going to show it in 2 minutes. So if I have space, I'm going to do it. So this is 1 week post-op, very small incisions. This is 1 week post-op. The AP view, lovely reduction. This is the lat view, absolutely spectacular anatomical reduction. And this is now 3 weeks post-op. Obviously, I'm going to have 0 callus, okay? 0 callus on the AP, On the left view, absolutely no callus, and no callus is happening, and this is absolutely part of the story. And then I have 7 weeks. The girl was doing so fine from a clinical point of view, but from a radiographical point of view, no callus. And this is absolutely part of the game. You just have to understand it. I am trying to make my Indian friends understand since the year 2010, no callus. And the patient was doing so fine from a clinical point of view because the mantra never changes. Clinical healing precedes, comes first, comes before radiographical healing. With 11 weeks, she was doing so fine from a clinical point of view. No callus in the AP view, but a lovely callus posteriorly. So we must see the callus from the posterior, the left view, and the AP view, and then you done the mathematics in your mind, especially concerning the clinical picture. So this is now 16 weeks. We can see callus in the AP view, and we must never forget another mantra. Bone remodeling will happen continuously and endlessly until 24 months. So this case, this bone will remodel and this callus will get better from a radiographical point of view until 24 months. This is written in 1 billion books. And this is 16 weeks in which we can see already some callus forming posteriorly, and this is going to get better and better until 24 months post-op. And this is the last time I saw her, 20 weeks, beautiful callus in the AP. This is going to be enhancing until 24 months, but it's difficult for me to keep these patients close to me because they say, doctor, I have nothing. I am clinically perfect. Don't ask me to come back. This girl, she was telling me, I have a baby. I have to take care of my baby. So it's difficult to convince them to keep on coming back. But this is the last time I saw her, 20 weeks post-op, 5 months, and callus formation. And see the size of these incisions. So there is a message here. If you do a posterior incision, in this case, you will do an incision as long as the distance from Ludhiana to Bangalore, and you don't have to do such you do not have to make such big aggression in terms of soft tissue when you can do such a tiny such a less morbid procedure like this one and see the sign of the size of the incisions. So this is the last time I saw her. This is the video. Ultra Mega Master small incisions. Ultra Mega Master cosmetical. The shoulder was doing fine. The elbow had good flexion, good extension. She was super happy. A very good extension on the elbow and a minimally invasive procedure. But the next case is the most interesting one. How far distal can we go? So this is the most distal case I have done in 22 years. And when all of you see this, 100% of the people, I repeat, 200% of the people who are watching this now are thinking it's impossible to do anterior bridge plating in this case, and this is going to fail. But the mantra never changes. 2 up, 2 down. So this is a very strong man. In June 2017, he had a car accident. He was drunk coming back from the disco. Too much hormones. He was a very strong man. The radial nerve was okay. See the size of his arm in terms of soft tissue. What a strong man. I put 2 down, 2 up, and 100% of you, I know you are thinking now, no. This is going to fail. This is going to collapse. Sergio is totally crazy. Okay. So the thing is, this is my personal way of doing things. When I do these very distal cases, I put these patients in a cuff and collar, and I allow only elbow flexion for 2-3 weeks, and then I release them to start doing elbow extension. This is not written in any book. This is my personal way of doing things. This is 1 week post-op, the immediate post-op. All of you are thinking that this is gonna collapse, I know, so just wait. So this is 3 weeks post-op, absolutely no callus, absolutely expected. And this is 7 weeks post-op. The callus was starting, but let me show you a video of the mantra, because the mantra never changes. In humeral anterior bridge plating, clinical healing precedes radiographical healing. So see how this boy was, this patient was 7 weeks post-op, because the mantra is absolutely obvious here. Clinical healing precedes radiographical healing. This is 7 weeks. So basically nothing in the X-ray, but he was feeling so fine. Lovely flexion, lovely extension, absolutely no pain. He's saying in Portuguese, não tenho dor, which means I have no pain. The radial nerve was fine. He was feeling so happy. And this is a caricature of the mantra. Clinical healing precedes radiographical healing. The patient was very happy at that moment. So this is 5 months post-op. Fantastic healing, lovely bone healing. So this is on the left side, the AP view. It healed perfectly. On the right side, the left view, wonderful healing. And this is the patient. The last time I saw her, I discharged him. And when people think, is this plate going to bother the elbow? Well, the answer is no. So see what this guy is about to do in this video. So he's super happy. I'm discharging him. He was in the gym, super happy. The shoulder was perfect. Não tenho dor, I have no pain. He told me, doctor, let me show you some push-ups. So this is 1, 2, no pain, 3, no pain, 4, no pain. He's saying, I have no pain, 6, 7, 8, 9, no pain, não tenho dor, 9, 10. He told me I can do much more. So, the question is, why to do a posterior incision as long as the distance of Patna to Kochi, when you can do only 2 tiny incisions? You can answer that for yourselves in your minds, ladies and gentlemen. And this is my last case to show that things go a little bit slower in older patients. So this is a 68-year-old lady in 24 August 2018. This is a mid-shaft case, short, oblique, obviously in my hand anterior bridge plating, no discussion about it. And she was 68. My personal record is coming up to 73-year-old patient, but she was 68, okay? So from a radiographical point of view, it's important to understand that in elders, everything goes slower from a radiographical point of view. So this is 6 weeks. She was doing fine from a clinical point of view, but no callus. No callus, and this is super expected. And now 11 weeks post-op, and basically no callus, but this is part of the game. 15 weeks, she was doing so fine from a clinical point of view. You can see some callus, okay, and she was doing fine since the beginning from a clinical point of view. No signs of loosening on the screws and on the plate, but no callus in the AP, and that can drive the orthopedic surgeon crazy from a psycho-emotional point of view if he doesn't understand the principles. 19 weeks, 5 months. You can see some callus posteriorly, callus, evident callus in the left view. And this 6 months, she was asking me, doctor, what the hell I'm doing here? I don't want to come back. I am perfect from a clinical point of view, but I only follow them because of pedagogical reasons to document bone healing. So we see some callus in the AP, and this callus in the middle of the screen, this is gonna remodel until 24 months, okay? And this is eight months, a lovely callus, बहुत sundar callus है, and this is the last time I saw her, okay? The callus was evident, 9 months, she was doing fine since the beginning. Please understand it, bone remodeling will happen until 24 months, 2 years, and evident callus posteriorly, she was doing fine since the beginning from a clinical point of view. See the size of the incision anteriorly, superiorly. See how small incision. This is not percutaneous. This is minimally invasive, and we have many keloids in Brazil. We cannot avoid it. So this is the lady, the last time I saw her, she was 69 at that moment. She was feeling fine. She was doing everything at home. The shoulder was okay, internal rotation, external rotation, forward elevation in the scapular plane, a little limitation in internal rotation, but she didn't do physio. She was doing everything at home, good extension. She was very happy. So let me finish you with telling this. Dr. Sergio, how many complications did you have in your life with this? You are only showing good results. So in other topics, proximal humerus fractures, rotator cuff problems, distal humeral elbow fractures, forearm fractures, I had 1 billion complications in my life, but not in this field. This is a happy world. So in 17 years, I had 1 non-union in a very heavy smoker and 2 post-operative radial nerve pulses with which fully recovered. I have one of them to show to you. I'm sorry for the quality of the video. This is October 2015, very obese lady. She developed a radial nerve palsy. See her hand. I'm sorry for the quality of the video. This is a very old camera. 2015, see a dropped hand, radial nerve palsy, which took 4 months to recover. I saw her in the last time was in February 2020, 4 years and 5 months post-op. This is not a good result because she didn't gain full elbow flexion, okay? This is not a perfect result. The elbow extension was almost perfect. She didn't do physiotherapy, but the radial nerve was absolutely fine. I'm going to show you in 1 second, and I'm coming to my final conclusions. So I just want to show you that the fingers were working nicely. This is 4 years post-op, and it took 4 months, 4 or 5 months. See, the hand is extending, the wrist, the fingers, the thumb. So it was solved. Good. So 4 take-home messages. The first one is this. This technique is a technique, humeral anterior bridge plating is a technique that can be done for any, and I repeat, any pattern of humeral shaft fracture, what includes diaphysial cases, proximal metaphysodiaphysial fractures, and distal metaphysodiaphysial fractures, as long as I can put 2 screws up and 2 screws down. Take-home message number 2. I always use a 12 holes plate, narrow 5 millimeters narrow plate, big fragments. It costs 10 rupees. It's a super cheap technique. In my opinion, and I will defend it to the end of my existence, only 2 screws. Kabi nahi 3 screws because it's not needed. And I only do DCP. I don't do locket, okay? When a lot of Indian guys come to me and say, should I worry about the musculocutaneous nerve? My answer is don't worry. I know the anatomy of the arm upside down, and it's not there. If you have to think about one nerve, is the radial nerve. So concerning the radial nerve, the question is, you will basically never find it, but if you find it, respect and not fear. Hamesha respect kabinahi fear, which means retract it delicately and everything is going to be all right. I have many photos of the radial nerve, many in this technique. I didn't put in this lecture because of a matter of time, But if someone wants, I can show through WhatsApp. It doesn't matter, but identify and demystify the nerve. So I just have to say thank you to all of you, gentlemen. It was a pleasure to be here. If anyone wants to keep my WhatsApp, I'm going to keep it 5 seconds, okay? And I invite everybody to go to my YouTube channel, in which I have 67 videos with more than 35 hours of children elbow education in English. Dhanyavad.
Thank you very much, Sergio. Thank you. There's actually a question on YouTube.
And Gautam sir also wants to ask something for the Bahut Strong lecture.
Yeah.
Yes.
Dr. Sergio. Yeah, this is Dr. Gautam Zaveri. I'm a spine surgeon actually, but a very interesting lecture and really enjoyed listening to it. Recently, we published a book on failures of fixation in upper limb, and there were a lot of humeral fractures which were fixed anteriorly, and we saw the implants fail, fracture going to non-union deformity. Obviously, you've not encountered this problem much in your practice because of the because of your expertise, but you must be seeing failures of other people. What are the most common causes of failure with anterior humerus plating?
Well, I don't have an exact answer. I don't have an exact answer, but what I have something to say, okay, sir. I have something to say. And this is very important. And I thank you for the question, okay? Because many Indian guys, they send me failures. And I'm going to tell you something. So you must understand the metaphor, okay, sir? So there is no half pregnancy. The woman is pregnant. The woman is not pregnant. There is no half pregnancy. What does it mean? You do it the way it must done, or it's not going to work. So many of them, they put 3 screws and 4 screws. And then, you are mixing things. You are making such a strong construction that will impede micromotion, and hence it will impede secondary bone healing. You see, so you have to think about the size of the plate, and you have to think about the number of the screws. So in my opinion, and I will not stop thinking like this, when you put 3 up and 3 down, the construction might be so stiff, it doesn't allow micromotion. And without micromotion, you will not have secondary bone healing, okay? So one thing that I have seen in some cases that my Indian friends, they send me, is that the plate is there. There is no signs of loosening on the plate radiographically. The patient is doing fine from a clinical point of view, but the bone union is questionable. It's not a pseudoarthrosis, it's a fibrotic union. So this I have seen in India, and my what I say is always the same. The plate is there. You don't see radiographical signs of loosening. The patient is clinically asymptomatic. Just wait and watch, okay? But what I'm telling you is this. In my hands, it works a lot, sir. And I have many complications in other topics, much more than I would like, but not in this field. This is a happy world, honestly speaking.
Right. Thank you, Sergio. Also, just to add further to it, you mentioned that you put only 2 screws above and 2 screws below in a 12-hole plate.
Yes.
Now that
Yes.
really gives you the bridge fixation, which is a relative stability. How do you explain 2 things? One, how do you explain the absence of callus in the presence of relative stability? And number 2 is that when you put in for these distal fourth fractures, where you've been putting only 2 screws, those screws are practically adjacent to the fracture. And all the length of the plate is utilized only in the proximal fragment, not in the distal fragment.
Yes.
So then it really doesn't follow bridge principle there, because the fragment, the distal fragment, the screws are right next to the fracture site.
Sir, I agree with you, but the fact is that it works. Okay, I totally understand you, but similar to the cases I have shown you, I'm not playing games. I don't need to do. I have 10 similar cases to show you. I can send it through WhatsApp if you want. This technique works, and there one more thing that I would like to tell. Okay, just putting our friends ahead on these distal cases. I am emptying the fracture hematoma. Okay, on this distal casing, on these distal cases, the fracture hematoma is going lost. So when people say you have to preserve the fracture hematoma for the fracture to heal, so this is a lie. Okay, this is a lie, because you have to think about the principle. So even if you wash away the hematoma, in my hands, it will work. But I can tell you something, sir. This technique is being done by a lot of people in India with a lot of good results too. Okay, so the popularity of this technique in India is very big, and everybody is happy. Allow me to make a joke, sir, because we make a lot of jokes in Brazil. Okay, all of the everybody is happy with this technique, but the companies. Okay, the companies are not happy. Okay, because they would like to do a $1 million implant, and we are using a 5 rupees implant. Okay, but hopefully we are not committed to companies, we are committed to patients. Okay, so the issue is this is a win-win game.
Right. Thank you,
One,
Sergio.
one
Okay,
question,
sir.
if I may.
Yeah.
Sergio, excellent presentation. I'm incidentally a colleague of Rajveer Chinoy. We work in the same hospital.
Yeah.
You mentioned Rajveer Chinoy earlier in the
Yes.
beginning of your presentation. So
Yes.
the few queries that I have, if you have a patient who develops radial, who's already has a radial nerve palsy, does your technique change? Number one. Number two, the
Uh-huh.
patient after your fixation then develops a radial nerve palsy. Would you go and then explore in that case, or wait, because traditionally, historically, nerves recover? And number three, if there is a multiple fractured patient, would you then continue to use the same technique uh, vis-a-vis mobilization and ambulation and so on? And lastly, what are your guidelines in terms of your, when you say traction is the miracle part? What are the guidelines? Because I saw your x-rays, the alignment on the lateral view is perfect. You are making a little compromises in the coronal plane, whereas valgus was. So are there some of the things that you talk, maybe it's there on the YouTube and I haven't seen? So those four questions, how do you kind of address? Thank you.
Well, okay, with all of these four questions, you want me to write a textbook, but I'm going to make it short. Okay.
Yes.
So the thing is, can you come to the first question, sir, please?
First
Because
question was radial nerve palsy. Before you start,
stop, please. When you have a radial nerve palsy, I think that, this is one of the most complex questions of the world. But if you see, the literature is controversial, and I am absolutely sure about it. But if you want to explore, my opinion, maybe exploring is best with a gigantic approach, but you must explore. I always say this to my residents: with a hand surgeon by your side, or with someone who is very experienced in microsurgery, with the sural nerve prepared, and to do whatever needed depending on the intraoperative findings. So the general orthopedic trauma or the shoulder and elbow surgeon like me, in my opinion, is not allowed to do properly this procedure, because you must have a hand surgeon with you, okay? A microscope or a loop, it doesn't matter. All of the hardware to do microsurgery, and the sural nerve ready for to be used. Okay, so I am very harsh on it. It's not, oh, what happens if you and me, if we diagnose a radial nerve tear? Do you know how to fix it? I guess not. Me, for sure not. So if you want to explore, have all of the things it's needed, including a plastic surgeon, a hand surgeon, someone very skilled with microsurgery and the sural nerve and all of the glues and all of the devices, okay? If I find, and the second question is about post-op
No, we haven't
radial nerve.
finished on the first one, Sergio. The question is, if the radial nerve is intact and bruised, in that case, you would put a plate posteriorly or you just bridge plate at the back?
No, and then the classical posterior plate in open
All right.
fashion.
Okay. The second question is, after your fixation, if there is a radial nerve palsy, would you then go ahead and explore?
Never, never. You know why? The question is very easy. The answer is very easy. First of all, if I have seen the radial nerve, I know that it was macroscopically intact in the end of the procedure. So it's just wait and it's coming. And if I didn't see the nerve intraoperatively, then another mantra comes. The mantra is, a nerve that you don't see is a nerve that doesn't exist, okay? So it's just a matter of waiting and the neuropraxia will recover. This is almost mathematical, sir, okay? You didn't see the nerve, you didn't touch the nerve, you know the nerve was there. Wait, sometimes it takes 4 months, 5 months. I have even seen a radial nerve coming after 6 months post-op, sir. Okay, but I would never explore, definitely not, because I know that the nerve is there and it was not touched, and it was not damaged.
Would it be possible that with your reduction, the nerve has got entrapped, and since you have not seen it, is that a concern for you?
I don't consider that. It's a good
All right.
question, but I don't consider that. And
All right.
in my practice, all of the few radial nerve pulses fully recovered.
All right. And your great criteria of what is an acceptable reduction, if they're in the coronal and the sagittal plane, I recognize traction is the key, and your partial screws up and down are the steps in your reduction. But are there some
Yes.
of the things where you've seen people doing where the reduction you would have said is not acceptable? Because I have seen X-rays where the angulation is huge amounts, and they felt that humerus is a forgiving bone, and therefore they accept
No,
much
no.
more.
You are right, sir. The humerus is a forgiving bone. We say in Portuguese, the humerus is like a mother, and a mother forgives almost everything. Okay, this is a beautiful joke, by the way. But the thing is, this is lack of good technique, sir. So, do you know how to achieve a good reduction? Intraoperatively, I didn't mention that, with your fists. One fist inferior, one fist superior, like with a closed hand, and then you reduce it under C-arm and you check it and you tighten your screws. And this is why this is a surgery that must be done by 2 orthopedic surgeons and 1 theater assistant, never 2 people. With 2 people, 1 surgeon and 1 theater assistant, you are ordering chaos, okay? So I like to do this. I like to do this with 2 residents and 1 theater assistant, which means 4 people, 8 hands, okay? In the moment of reduction, if you have 4 people, I know I operate with residents. Sometimes I have 2 of them, sometimes 1, but at least 2 surgeons and 1 assistant, okay? 1 is doing traction. The other one is with the fists. We are adjusting reduction under C-arm control. And the third one is tightening the screws.
Right. And the last question, in multiple fractured patients, does your technique change because you're providing biological fixation?
Sir, well, it's not so easy to answer, but I guess there's still a space. There's still space. Okay, there's still a space. Just to mention something, maybe even Desai Dhaval doesn't know. We have published an article done in India, okay? on this technique with 3 countries, Brazil, UK, England, and India, with Dr. Harpauseli in Dayanan Medical College. We operated 20 patients. We published the article. It's published. I can send you through WhatsApp immediately after this presentation if you want. And all of the cases were polytrauma cases in Dayanan Medical College, all of the cases. And in all of the cases, they put they used this technique and the patients had good results. So in my opinion, it can be done in polytrauma too. Okay.
So Vivek, it should change for a polytrauma, isn't it? I mean, it should be even more preferred, I would think so.
Uh-huh.
You would, if they are being mobilized with a walker, somebody with a lower limb fracture, somebody has to use a walker, somebody has to get up using a support, then probably I would need something much more into inverted commas, something even
I
a
think you
little
would
more
allow.
stable.
We'll come to more on this as we take more this thing around there on the discussion. We'll come to this point. Yeah.
Okay.
Sir, I have a question. I wanted to ask that when you put the first screws that you do you drill them completely or you drill them just half and take only one cortex in your 2 screws that you're putting on either side? Because if you have drilled them completely, then as soon as you tighten them, the chances of your reduction and the plate moving are very high. So how do you achieve that?
Sir, sometimes I have difficulty to understand English because of the Indian accent. So can you speak a little bit slower and ask me again, but slower, please? If not, I am not understanding you. I'm sorry, sir.
Okay. So when you are putting the 2 screws on,
Well,
you put them only in one cortex. Do you drill
yes.
both the cortexes or do you drill only one cortex, get the reduction and then drill the second cortex?
No. Good question. I mentioned that. I drill both of them. I drill the 2 corticals initially, and I go until the end and I unscrew them. But the perforation is there
So
since the beginning.
Question is that even if you try and do a reduction now, because you have already pre-drilled those the screws, the moment you tighten them, the bone is always going to go in the direction in which you have put the drill, and then you might lose the reduction that you have initially achieved.
No.
Does it happen?
Good question. It will not happen because I am controlling reduction with my 2 fists. And this is a good question. And I tell my residents to screw slowly, not fastly. Slow, 1, slow, and then I check. Slow, and then I check. But this is a good question. Very nice question. But you have to hold reduction with two hands, one in the inferior fragment, one in the superior, okay? Under C-arm, go slowly, and then you fix it. I like it, your question. Very good one.
Ashish, can we take the 2 YouTube questions and then move on?
Yes. So Sergio, there are 2 questions on the YouTube channel. One is by Dr. Smith Shah, and he asks how to convert to open reduction if we are struggling. That is one. And second question is by Hari Prasad, who asks, is it the locking screws or eccentric screws in a normal DCP?
Can you, let's come to the first question, please. Can you do it again?
Yes. How to convert to an open reduction if you are struggling with a closed reduction?
Well, the answer is, I have never converted, and I guess I will never do. But the question is, if you're struggling and if you are suffering too much, you can connect both incisions, okay? And then you will do nothing like an anterolateral approach, okay? An anterolateral approach, everything is going to be in front of you, and you can do open plating, classical open plating through an anterolateral approach.
Yeah. And the second question was, are these locking screws or they are eccentric screws in a normal DCP?
No, they are normal.
Screws.
This is let me go further just a minute, okay? Because this is so important. The issue is we believe many people like me believe here in Brazil that we should, but pay attention to this, please. Pay attention to this, please. That we should not use locked screws because locked screws would lead to such a stiff construction that that stiff construction would impede micromotion and hence impede secondary bone healing. Okay, so we believe that with DCP screws we will have more micromotion than with locked screws. Okay, but this is just uh, a personal point of view, and still in my public hospital, we have infinite patients with finite money. You understand me? So we prefer to use very low cost implants in these cases to save money, to use filos when needed or locked plates when needed. So, but in the end of the game, sir, I have never done with locked screws. I don't feel comfortable doing with locked screws. And someone and the other gentleman, this I am gonna say something interesting. The other gentleman, the spine surgeon asked me about failures. Okay, so I have seen many Indian guys putting 3 locked screws and 1 DCP. So why are they doing this? Okay, remember the metaphor. The woman is pregnant, the woman is not pregnant. If you stay in the middle, you will fail. Okay, so believe the technique, and see, I have been showing cases for 16 years. Is not such a small time. So I'm trying my best for 16 years. If I cannot convince my Indian friends, I'm super happy, but I'm doing my best. You know, everybody in South America is already convinced, okay? And we are talking about 20 countries, because the technique in Argentina, my friends are reproducing this so much in Buenos Aires, in the north, in the south. So you see, we are the same. We are the same human. We are the same species in Argentina, in India, Homo sapiens. The biology is the same. So if you reproduce it, believe me, in my opinion, it will fail. It will work. Dr. Desai, which is a mega master, he's a monster of orthopedic trauma. He still likes 3 up and 3 down, but I love him in spite of all of that.
Excellent.
Okay.
Thank you very much. Thank you very much, sir.
Okay.
Shall we move on to the next one?
Is there any other question?
No, not at the moment. We'll take them
Okay,
as they
good.
come in on the YouTube channel. Yeah.
Okay.
Ashish?
Parag, is that your screen?
Yes.
Yeah, I can see your screen. Yeah, I can see the presentation. Yeah.
Okay. Thanks, Dr. Sergio.
Yeah.
Some of the points that you mentioned, I totally agree about the nerve. I would like to give some glimpses of tackling the radial nerve injury when you deal with the humerus shaft fracture. And this is the scope of my talk. What are the possibilities of nerve injuries and how do we analyze them? Then what are the treatment options and how do you decide the algorithm to treat it? Let us start with first case, a 58-year-old gentleman, a manager from an IT firm. He had a polytrauma with humerus fracture and an intact radial nerve. And he had these medical comorbidities. So these nerves, the radial nerve was intact pre-op. And then immediate post-op, he had a palsy and the complete, a high level radial nerve palsy. And then we started discussion on on WhatsApp. At 8 weeks, the radial nerve did not recover, and he was asking about any further investigation. We started with the rehabilitation protocol, but one point I would like to say that when you are doing a radial nerve palsy, especially comminuted humerus fracture, when you are dissecting it, please document it. And the best way to document any particular nerve is taking a, is taking a proper picture. And then at 16 weeks post-op, the nerve completely recovered. So here the message is, if you have seen the nerve intact, then observe and wait for the recovery. It will recover. Okay. The only thing that you may, cause, if it doesn't recover in 3 months, then yes, then you have to take a call about further investigation. In case of open injuries, there is no discussion that, we have to explore. Do you have to debride the nerve proper? The wound properly, find out, identify the proper cut ends of the nerves, and after fixation, you try to repair the nerve. And this usually, as Dr. Sergio mentioned, in open injuries also, you should take consent for a grafting, the sural nerve grafting, but the definitive fixation is mandatory in such cases. And usually, once you repair the nerve, radial nerve amongst other three, median and ulnar, radial nerve is the best nerve to recover. And it definitely recovers. It takes around 6 months minimum. Brachioradialis is the first one to start recovering, and extensor pollicis longus is the last one to recover. And that's the result. After the open injury, the elbow range of movements you get full, and once you just do a good primary repair. So the first technique, if you have seen the nerve, observe it. Second, if you can get the direct cooptation of the nerve, it's the best treatment to get good result. So in open injuries with neurodeficit, the exploration is mandatory. Then we have seen here that a 50-year-old gentleman with 8 months post-op, we had a high radial nerve palsy, 8 months post-op. Okay, now if you see the K wires that has been put to fix the fracture, probably that caused the nerve. And here you have to explore, we had to explore the nerve, and you see here the normal course of the nerve and a neuroma formation. And when we explored it, we found out definitely, as discussed, the K wire that was bulging out from the cortex, lateral cortex, and that was creating, that was causing that caused radial nerve palsy. So as it was, long-term post-op, and we had to just remove the K wire, the nerve was intact, and I had put just a tissue glue to put, it was not a frank rupture, it was just a piercing injury of the K wire, and this he recovered completely. I removed only the radial, the K wire that was inserted from medial aspect. I removed only that. The others I did not remove. The message: if there is a strong localized T-nail sign, and if there is no recovery in 3 months, and of course, if your implant location is suggestive of some kind of injury, then always consider exploration. Now, sometimes you will come across with this lower third humerus fracture, and the commonest entity, Holstein-Lewis fracture or Holstein-Lewis syndrome or lesion, where the nerve enters from posterior to anterior, lateral compartment to anterior compartment, and if there is a fracture there, that because of the entrapment of the nerve, there is this patient had post-operative immediate loss of finger extension and thumb extension as well as wrist extension. The triceps were normal, brachioradialis was weak. And when we explored it, and if you see, the nerve was probably entangled at the fracture site. So this was the proximal end part of the nerve, and that was the below that was the branch to the long head, and this was the opposite side. Okay, it was after the dissection. And if you see this, these were the two cut ends of the nerve, and the nerve which was the entering from posterior lateral side to the anterior aspect, it was stuck underneath the plate, and we had to cut that and did a sural nerve grafting. We had to repair it. You have to prepare the cut ends of the nerve and try to do a nice epinural end-to-end repair. So this is after preparation of the nerve. We had to take a sural nerve graft, bridge the graft, and put a T-seal, that is a tissue glue. And usually radial nerve is very big, and it requires at least 2 or 3 cable graft. To prevent the irritation of the plate against on the nerve, we had to do a tricep, because we explored the nerve at 3 months post surgery, and we usually always do a soft tissue cover so that the nerve does not get irritated on the implant. Some of the simple shaft fractures, even after post fixation, like this case, after almost around 4.5 months post op, patient developed a palsy.
So
And when we
main trunk
explored
of
the
radial
nerve,
nerve,
probably it
either the
was a
triceps branches.
attrition rupture or
This is the
something. This
tricep
was the
branch,
proximal end of the nerve,
probably going in lateral
which I
head.
am holding here.
This is the main
And
trunk of
so
radial
this was
nerve.
the distal end of the nerve.
It had gone
It
here.
was
We
getting
dissected it out.
entrapped there around the
You
plate
can see
side.
the
And we took a sural nerve graft. These are the two cut ends of the nerve, and we breached with the 4 cables of sural nerve graft. As I told you, if there is an immediate post-op deficit, or if you don't have proper communication with the primary operating surgeon, if there is no recovery in 3 months, always explore and take a consent for grafting. The decision algorithm here, if there is a humerus fracture with radial nerve palsy, primary, if there is a primary radial nerve palsy before surgery, I would recommend considering open reduction, see the nerve and deal with it. If it's secondary, like it has happened after the surgery, okay, so if there is no recovery in 3 months, then you consider nerve conduction study and electromyography to know the type of injury, but always take a consent for exploration. And you should always consider early exploration in open injuries and injuries associated with vascular injuries. Now, just to for the late presentations, like more than a year or 13 years, 13 months or 15 months post-op, the late presentation of radial nerve palsy, like this is the patient had a wrist drop, 15 months post humerus fracture. His wrist was recovering, but rest of nothing recovered. So he just had some recovery in the ECRB, but there was no recovery in EDC and EPL. So here we perform the standard tendon transfer. We use 3 tendons, palmaris longus for extensor pollicis longus, flexor carpi radialis for extensor digitorum communis, and pronator teres for ECRB. It's a very standard transfer with the amazing results. But as far as my recommendation is young patients who are coming to you within 6 months of injury, always consider a reconstruction of nerve rather than a tendon transfer. In chronic cases or a medically compromised patients, you may consider a tendon transfer. So this is about the radial nerve palsy in a humerus fracture algorithm. Thank you so much. I am happy to take questions.
Thank you, Parag. Thank you very much. And I would just like to first start with the panel if they have any questions before I fire a question.
Yeah, should I stop sharing the screen or?
Yes, please. You can stop sharing.
Sir.
Yes. Yes, sir.
Can I make a question?
Yes,
Yes,
please,
please.
sir.
Okay, so Dr. Parag, बहुत सुंदर lecture, ठीक है, very beautiful one. So
Thank you.
the thing is, I totally agree with you in many points you have said, but one, and especially when I see my cases, the thumb is the last one to recover after a radial nerve palsy. I see this all of the time, but I agree with you up to an extent, but not at all, because when you say after 3 months you should explore. See, sir, I have seen many radial nerve palsies spontaneously recovering after 6 months, after 5 months, after 8 months. I had one case after, and especially, I am not, as we say in Brazil, I am not discussing the sex of the angels, if you understand the metaphor.
Yes.
Okay. But I work with heavy trauma and many gunshots. So I have more experience that I would like to have in radial nerve pulses after gunshots. Okay. So, and in these cases, especially, there was a gunshot, 1 million pieces of bone exploded because of the bullet, and then you operate it. And I have seen 3 or 4 cases, 4 max, in which the radial nerve just was working again after 7 months. So, see, sir, so considering my experience, it's just my experience, it's 17 years doing this all of the time. But the thing is, I have seen spontaneous recoveries after 4, 5, 6, 7 months. And so considering that, do you still think that we should explore every case after 3 months?
Okay. I would like to answer this question. At least we must have a EMG nerve conduction study and a
Sure.
high resolution ultrasonography to understand the intactness of the nerve if possible. The
Yeah.
EMG nerve conduction study, I study those reports irrespective where it is done. Sometimes we get a bad quality nerve conduction report. But if compound motor action potential, CMAP, of the
Mhm.
report in brachioradialis and extensor pollicis longus, if as compared to the opposite side, the CMAP is less than 50%, CMAP
Mhm.
is less than 50% as compared to the opposite side, then I would definitely opt for exploration. If patient is going to have a close follow-up with me, I will wait maximum 4.5 months, because
Mhm.
beyond that, 7, 8 months, then the muscle atrophy and the discussion of getting it re-innervated in
Yes.
elderly gentlemen like more than 45, it
Uh-huh.
gives bad result. It may give
Mhm.
bad result. So sometimes a negative exploration, see yourself and tell, yes, boss, nerve is intact. You may end up doing a microneurolysis around the fracture site, and but you have seen it, and then the surety is much better. But rather than before exploring, I would take the investigations, into consideration. And if my investigations are negative, I mean, they are giving me a hint that nerve could be injured. Because if radial nerve is injured, in 6 weeks to 2 months, it has to show brachioradialis.
Mhm.
It has to show index finger extensor indicis propriosus. It has to, that
Mhm.
is the second muscle to recover. Then it has to show extensor digitorum communis. Then it has to show ECRB, then ECRL, and then EPL in the sequence. But at 3 months, in a humerus fracture, if brachioradialis is not working, very likely the nerve is either partially axonotmesis, partial injury, or a complete injury.
And we just have to remember that the quality of the electroneuromyographists makes all of the
Yes.
difference, because
Yes.
it's operator dependent procedure.
Yes.
And especially in the public system here in Brazil, to find someone who is good, the waiting list is endless. So
Yeah.
in
So
India,
I would
in
recommend.
India, it must be complicated.
I would recommend to a surgeon. The technicians are aware of names of the muscles where we put the needle. So please
Yes.
mention in your report. Please tell us CMAP of brachioradialis and extensor pollicis longus. That's all.
Okay.
If and compare it with opposite side, then you take a call, because it is very
Okay.
easy to palpate brachioradialis and ask them to know the CMAP of that. It will give you a better answer. Yeah.
So, if I may, Parag, very good
Yes, sir.
presentation. My question to you would be, there are two, three scenarios. One where somebody else has done the surgery and you don't know what is the status of the nerve. So right now we have a very good ultrasonologist who kind of exactly with a marker, a Mehndi marker, tells you where the discontinuity is or where there is a narrowing of the nerve.
Yes, sir.
So that becomes very useful. And then we go with in our case, at least I'm lucky to have somebody who's a peripheral nerve expert who can then come and take over the management. The third thing as an observation is the humerus fracture should be treated like an exploration of a radial nerve, and the fixation is an incidental finding.
Agree.
But so that is more at the level of the residence level, where the fixation doesn't become primary. The isolation of the radial nerve and retraction becomes the first goal before you consider a fixation. So those
Completely
were the
agree.
few things that I've as of now in my practice is what I'm following.
Agree, sir. Completely agree. Yes, sir.
So, Dr. Lad, can I just stir up a little bit on this topic?
Sure, sir. Sure.
So, the evidence says that there is more iatrogenic radial nerve pulses with plating compared to nailing. And I think the evidence is still not clear whether there are more now palsies in open reduction versus minimal invasive. I guess there are probably more in reduction. Sergio might say on that. And the corollary to this question, I also wanted to ask Sergio is it better to see the nerve and protect it and then not retract it? In order, you would answer first, then maybe Sergio would add to this.
Yeah. Yeah, that's the right word. We don't retract. You put an infant feeding tube, you put a umbilical tape, and
No, I'm just talking about when we do the anterior breech plate in the lower incision.
yes.
Is it better to see the
No,
nerve
no.
and keep it and
No,
not
sir.
put a retractor?
No, if there is no preoperative palsy, you don't need to see the nerve. You just do anterior approach, minimal invasive plating.
Can I say something? Can I say something, please? Please.
Yes.
The thing is, until 7 years ago, I preferred to see the radial nerve in humeral anterior bridge plating. Then I talked to a lot of people and I understood in my mind that I should not see the nerve.
Oh,
So I
agree.
started to do my incision more medial. So I didn't talk about the anatomical landmarks of the incision on my lecture because of a matter of time. But when I do the distal incision, I do it immediately lateral to the distal biceps tendon, immediately lateral, okay? And then I split the brachialis, and believe me, the radial nerve is not there. The radial nerve is not there.
Agree.
So in the last 7 or 8 years, I stopped seeing the radial nerve. I don't see it, and believe me, if you have a palsy on a nerve that you didn't even see, to me, it's quite reasonable to assume that if you have a palsy, it will recover. The issue is that it's very easy, Parag. We say this so much in Brazil. When your friend has a radial nerve palsy, you talk to him and you say, take your time. Everything is
Yes.
going to be okay. And it happens to us and to me, I want to shoot myself. So when you are the surgeon, I mean it. We must have psycho-emotional balance as
Correct.
surgeon, psycho-emotional balance to rely on data and to wait for things to come and have, especially from a medical legal point of view, Parag, to have a good relation with the patient.
Correct. Correct.
And I totally agree with you that making a picture, not with a picture with the iPhone or the smartphone, is important, especially from a medical legal point of view.
Agree. Agree. Thank you.
Excellent. Parag, there was a question on the YouTube, but I've just answered that because it was a point that we have alluded to. I think that more or less the questions are sorted. And thank you very much. Shall we move ahead, sir?
Yeah.
Yeah. So thank you very much, Parag.
Thank you.
What we'll do in the meanwhile, we'll just shuffle the order a little bit. So we'll get Dr. Vivek Shetty, sir, to talk about his presentation first. And I'll be moving the slides and we'll start the presentation. It is on distal humeral fractures. Is my screen visible, sir?
I can see.
Yeah.
Thank you, Ashish, for invite. Thank you, BOS, for the invite as well. Distal junctional fractures. Now, Sergio is going to kind of shoot himself when we see a lot of these plates and nails being used for these fractures. So bear with me, Sergio. There are a few. I'm just going to run through 5 cases that I'm going to show on these junctional fractures and move on, and let's have a discussion on this. Okay, next, please. So all of us in this area, the forces acting from the elbow as well as from the humerus, we have our own way of coping with these lower fractures. Some of us are nailers, some of us plate these. And now there is a trend to do a dual fixation, which I kind of strongly resist in a primary scenario. So we need to keep this in mind, and let's see where we lie in these fractures. So the first case, next slide. Thanks. So this was a young man who had a fracture, a 1-2 A3 fracture, and we know from the first talk what somebody would put a bridge plate in this scenario. The radial nerve was intact. So what happens is when somebody is wanting to do a nailing, a humeral nail should never be hammered. So when you see something like this on the X-ray where the cerclage has been put in, that means the fit is too tight. Humerus doesn't tolerate distraction very well. So I would say go to the extent of reaming 2 mm higher, bigger. The nails that we have here is we have a 7 mm nail. You get the nail in and it needs to be maneuvered rather than hammered in. The surgeon recognized this and felt that he opened it and put a cerclage around it and then put one screw. Now that's another thing that I would probably not do, because if you are thinking of nailing and if it is a junctional fracture and if there is a wind swiping varus valgus effect and a torsional effect, then the least one can do if you are opting for this, and if you see this, you need to have a fixation on the others in a different plane as well. So 2 screws in different plane, and if you recognize this fracture is going that far down, maybe an added plate would be my option at this sitting. So this is an intra-op finding done elsewhere, and this was what was seen. Next, please. So this at 2 months, this is the surgeon was waiting for him in the cuff and collar, very limited mobilization. So at 2 months, there was an increase in the gap. Next, please. And there was a radiolucency around. And this is how he presented with arm pain, difficulty in moving objects. He was an IT professional. So at this stage, there is a wind swiping of the nail in the canal, and everything is falling apart. And therefore, most of us would consider a reasonable option to revise this fixation, have the nail taken out, and then put in an added plate, and if need be a graft, because there's not much biology happening at the fracture site. And since you want an added support further down, then I would probably run an extra articular plate down the lateral column, add a bone graft. That was my strategy. Next. Was my strategy. So can we move on to the next, please?
Can you see the screen? Is that?
Yeah. So this was what was done. The approach posterior proximal, the nail was removed, and then he ran down the plate on the lateral column side. There was a bone graft put in. The next slide. Yeah. And that was the post-op, and slowly you started seeing callus and the fracture slowly healing. Patient immediately was very comfortable. I was concerned about his shoulder movement, because the shoulder was secondarily violated again in the process of removing the nail. So the rotator cuff was what I was worried about, but he had decent range of movement. Next, please. So he was healing very well. Next slide, please, Ashish. And that was his range of movement at 3 months. His internal rotation was good, and he was extremely comfortable at 3 months. And looking at the fracture gaps closing and the callus, the first sign at 3 months, I'm comfortable that he would go on to heal. So this was at his last visit. It's an ongoing story, but I think it is a good ending that I'm expecting. Next, please. Another case. Now, this is one of mine. He is a medical oncologist, a resident, fell over an outstretched hand, and given the clean nature of his fracture, in this case, I opted to do a interlock nail so that I can get him back to operate. The nail that I put in was a little tight, but I was comfortable with the hold, and I'd impacted the fracture. Next. And this is what he had, a closed nail. Now, on the follow-up at 6 weeks, the X-ray doesn't show up. There was a little callus. There was a small crack that I started seeing at the distal end of the plate. He started becoming a little uncomfortable by the 3rd month when he followed up. Next, please. And this was at 7 months. There is a radiolucency seen. Now, in hindsight, in a situation like this, where if I were to pick up that crack distally, probably I would have added another screw in a different plane, identified the nerve, and then probably would have added a lateral to medial screw, probably would have got away. In this case, he was uncomfortable, and in the 8th month, next slide, gave him functional brace. But by the 10th month, the nail was wind swiping in the canal. So what I opted to do was not go back again and remove the nail and violate his shoulder again. What we did was added a bone graft, added another screw, and add an overrided unitized plate onto that. Next, please. So there's a combination of a plate where I kind of pass the screw through the plate, through the hole in the nail, proximally and distally, and added a tricortical graft in the non-union site. And we have a series of around 20-25 cases in proximal femur. This is the first time I attempted, rather than violating the shoulder, to add another plate to hold that together. Next, please. And that was his. At 1 year after the unitization of a nail and plate, the bone solidly healed. And the last X-ray, he's already moved on. He was part of the postgraduate student. He's now moved on and practicing. We asked him for his range of movement. Next slide, please. And just play the video if you could, please. Yes. So he's got a full range of movement all around. And he also is a fan of old-fashioned gymming. And this is what he kind of sent me. He said, this is what I'm doing now, a year down the line, with good range of movement and having successfully got the fracture to heal. So we'll follow on with the other cases, and then I would like to kind of catch up on a discussion on what others would have done. This is again a junctional fracture, a very short plate, and as Sergio was mentioning, 3 screws, maybe a longer plate, but a good working length may have kind of helped this patient. Again, this fixation of forearm nailing and plating was done elsewhere. Next. And this is, mind you, in 2007. So like Dhaval, I like 3 screws up and down, and I in a non-union scenario, definitely this was before the extra articular plate scenario. So a bone graft and a plate running down the lateral column. So maybe later on, Sergio, if you have just 2 screws in the distal, would you be willing to run the plate down the lateral column and add 2 screws? So on the lateral column, and whether you've done something like this in a primary scenario, mind you, not a non-union scenario. So this is what was done. Next. And this is at 4 weeks. Yeah, moving on. And at 8 months and at weeks to go on to unite. And that's at 18 months. So a good solid union achieved with a tricortical graft and a long enough plate. Next, please. So short plate, the humerus, if you're adding a lot of screws, short plate is a big no-no. You don't want to put in, and if you've kind of put in a interfragmentary screw and circlage, then the working length becomes really small. So this is a recipe for disaster. Again, this is done elsewhere. Next. So the theme is, in these areas where you can't get a long enough plate, then the extra articular plate has helped. And in this non-union scenario, tricortical graft was put in, plate long enough to kind of make sure offload the fracture site and compress. Sometimes I use a Muller compression device in a non-union scenario. Next, please. And that's at 6 weeks. At 8 months. And with good range of movement in his elbow. Now, the last one, yeah, moving on, please. Again, if you add too many of these screws, the whole, it's a disaster. So even if you add the number of screws on the plate, the fixation is just too rigid. So we saw at one end of the spectrum, just 2 screws up and down. Humerus is a very, very kind bone, and like one of my teachers used to say, if you have the humerus in the same room, they will just be they'll unite. But if you make it too rigid a construct, then there is a disaster waiting to happen. So this is what was done. And this guy came to me 18 months after his fixation. Whatever bone that had united, butterfly fragment, I didn't touch, and ended up putting in a long enough plate. There was one broken screw. I didn't make a attempt to try and take that out. And the follow-up X-rays at 1 year, he went on to moving on. At 4 months, and at a year down the line, he had good range of movement and callus formation, and he was very comfortable. So the take-home message is we need to get it right the first time. How we reach there, whether you need to use a relative stability with a bridge plate, or if you have to use a nail, and if you are somebody who is very keen on a nail, then it should not be impacting. The nail should just walk in. So your reaming should be 2 millimeters bigger than what you normally do. If it is a junctional fracture, then I would probably add distal screws in 2 planes. If there is a radial nerve involvement, then I'd rather go for a plate than a nail. Plate, good working length, and we have seen bridge plating or a post plating. In a non-union scenario, I've started seeing dual fixation, a nail plate combination or a 2-plate combination. I feel in a humerus, if you have a long enough plate and a tricortical graft and compression, I have not felt the need for using a dual fixation. Like to hear a comment of my colleagues. Thank you.
Thank you very much, sir. I'll stop sharing the PowerPoint. Yes, I think we can take some questions. Yeah.
Yes, Sergio.
Well, sir, see, I have 2 points. First of all, there is something that I always say to my residents, and I think that this is missing in the orthopedic education programs in many places in the world, including mine when I was a resident, which is whenever you put a synthesis, remember that someday you might have to remove it. Okay, so you see, I don't want to jump in the discussion. Why do I hate, and I hate humeral nailing so much? I hate it. Okay, I don't do it. Thanks God I don't do it. I have a supermarket list. We say in Brazil, you go to the supermarket, you have 100 things to buy. So I have a supermarket list to tell why I hate humeral nailing. We can discuss for 1 hour because I have good background on this. But the issue is, if you put an nail and integrate nail in the humerus, remember that someday you might have to remove it. Removing an integrate nail in the shoulder, sir, implicates in a destruction of the rotator cuff, which is not acceptable to me, because my life is literally dedicated to save rotator cuffs, not to damage them, using them as an approach. This discussion happens for 22 years in my life. It will not get to a final point today, but it doesn't discredit me to put in you the problem. So removing an integrate nail in a young patient or in a middle-aged patient implicates in a destruction of the posterior superior cuff, which is not acceptable in my practice. This is one of the many supermarket list reasons I have not to be a nailer, okay? And this is take-home message number 1. Whenever you put a synthesis, remember someday you might have to remove it. And the complications in humeral nail, when they happen, they are catastrophic or potentially catastrophic. And the second one is, you see, sir, if you had done humeral anterior bridge plating in many of these cases, maybe the end of the story would be better, I guess. I am suspicious to say, okay, I'm very suspicious, but it would be different. So the issue is there is another message, which is respect the biology of the humerus. So when you go too aggressive, maybe you will have a lot of complications. So The issue is minimally invasive osteosynthesis. They must be the working horse in the management of humeral shaft fractures. It can be humeral antegrade nailing or humeral anterior bridge plating, but classical plating should be an exception, okay? Must be an exception. This is super well established in Brazil, super well established in South America, and I guess it's established in India too, but not so much. I see a lot of younger surgeons nowadays, they are making gigantic approaches posteriorly, and I think that these approaches, they should be a mega exception. So in my public hospital, we do one posterior approach a year, maybe every 2 years, and we take care of 1 million patients. So see, sir, I think that the message is whenever you put a synthesis, remember that one day you might have to remove it and deal with the consequences. And two, the more you respect the biology of the arm and the humerus, the less complications you will have.
I take your point, Sergio. All the folk, except for the one nail where you saw me leaving the nail well buried. So
Yeah.
other than that, all the other 4 cases were done elsewhere.
Yes.
Posterior humerus plate is still a very popular approach in India.
In India.
There are a lot of
In
bridge
India.
plating in India, but
Yes.
there are posterior plate is still a very, very common surgery for a mid shaft fracture of the
Yes.
humerus.
Yes. Yes.
The nail case, that case number 1 that I showed, the nail was sticking out.
Mhm.
Otherwise, I wouldn't have taken that nail out. I would have just left it as an intermedullary device. The case that I
Yeah.
did, I left it there because it's well buried. I didn't want to touch the rotator cuff. I just added a bridge plate and a graft, and that was good enough. But the first
Yes.
case where the nail was, it was sticking out, and I couldn't. I didn't want him to have a painful shoulder and a healed fracture. So that was a justification. Otherwise, I take all your point on board. In a non-union scenario, the question, would you still use an anterior bridge plate to get that to compress, or would you go posterior?
No, I would go posterior or anterolateral with a plate and with 1 billion kilos of graft taken from the anterior iliac crest, or I would say, or artificial graft if there is money enough to buy it, you know. But I think that in non-union you have to play to win. I think that there is no role of humeral anterior bridge plating in the management of non-unions. But let me tell you something, sir. I'm very happy to tell you that I have been inferring in the last 17 years now turn it into a statement coming from you, sir. So I have been having the feeling in the last 17 years that posterior plating of the humerus is so still popular in India, and you have just told me that, okay? So just for you guys to know, I am not saying we are wrong, you are right, we are right, you are wrong. I'm just telling you that, and I ensure this to you. Posterior plating of the humerus in Brazil, in South America, hopefully is an exception. Dr. Desai Dhaval, Dhaval Desai can ask Dr. Vincenzo, he will tell him the same. So the thing is, I don't know why in India is still so popular, okay? Because we can have so less complications, you know. So the issue is, my message is always the same. Posterior plating of the humerus should be an exception. Only in very specific cases. You must go to conservative management if there is a space, of course, but minimally invasive procedures. You can be a nailer if you want. You can do anterior bridge plating if you want. And in the end of the day, sir, nailers will nail and platers will plate. We will never change that, you know. People like black, people like white, and this is the human being. But as long as we understand that posterior plating should be an exception, I am absolutely happy. Far enough to me.
Just a follow-up question, Sergio. You talked about a lot of bone grafting. In my practice, if I see a non-union, I tell them that I'll make the humerus a little shorter. I just cut out the fresh edges, and they accept a shorter humerus rather than packing a lot of bone graft with a gap in and trying to compress. So I would just freshen the edges. I'm quite happy to accept a shortening of up to 2 centimeters, get good fresh bone edges, and then get a bone end-to-end compression rather than packing a loads of graft with a gap.
I'm going to tell you two things, and the second one is mind-blowing, okay? The first is literature allows us to shorten until to 3 centimeters the humerus, and it's
Yes.
okay. So let me tell you something very interesting. When I was in 2010, which means 16 years ago, I was in World Congress of Shoulder and Elbow Surgery in Scotland, in the city of in Edinburgh, the capital of Scotland. And there was the International Congress of Shoulder and Elbow Surgery 16 years ago, and there was a symposium on humeral and clavicle non-unions, okay? Good. So some guys from Germany, they came and they said, when you are dealing with a clavicle non-union, and when you are dealing with a humeral shaft non-union, when you put graft from the iliac crest, when you think it's enough with your eyes, it's time to put double. When you think that's enough, it's time to put double. So I have the slides from 2010 in my house here. So the issue is, the message of that symposium was, if you are dealing with a non-union of the clavicle of the femur, you have to play to win. Apart from all of the construction, the plates and the screws, you had to add a lot of biology, which means a lot of graft. So in this sense, sir, I think that putting graft is always good enough. This discussion is endless. How much should you put? But that symposium was a landmark in my life. When you think it's enough with your eyes, macroscopically, it's time to put double.
Right. Well, my experience has been totally to the contrary, because my feeling is non-unions are instability rather than biology. And over the
Uh-huh.
period of the last 20 years, I have felt, and my philosophy has changed. The extent of bone graft has gone down so drastically that I feel that the biology will follow if you provide stability. And therefore, the cases where I have done fixation and provided stability, because the bone grafts that I've put, and I've got a series of around 15, 20 cases over the last 20 years, the
Yeah.
amount of bone that I've put are so minuscule, just tricortical graft, intramedullary and compression. As long as I provided stability, graft, the biology will follow, is how I have looked at it. So
Okay.
just a point of view, just a point of view.
Excellent. That was a great discussion. So there are a couple of questions on the YouTube channel. I mean, you can go and answer there, but there's one particularly one which I would want you to answer is what to use, a plate or a nail, if there are butterfly fragments, maybe one or two. It's directed to you, Dr. Shetty.
So if it depends on the location of the fracture. If it is proximal third, middle third, and if the canal is wide, and as the nail, if the moment I feel that I can be able to preoperatively feel the nail would be able to go in without using a mallet, then I would prefer a nail. But if I feel that I will not be able to kind of get the nail through, the canal is very tight, then the option for me is a plate.
Excellent. I think that answers it. I think for the viewers, just keep your questions coming. We and the faculty would try to answer them on our YouTube channel on Ortho TV and the BOS. Now I'll hand it over to Dr. Dhaval Desai, sir.
So Ashish, thank you. I think I purposely went in the end because I think to make justice to this topic of what's the equipoise for humeral shaft fixation, I have to present what is perhaps a little balanced view, but with my own bias And I must admit that having learned from Sergio over the last 2 and more decades, I am now probably more and more convinced that humerus needs to be treated in a biological way. Most of the times you will be able to do that with the anterior breech plate. There are some exceptions, circumstances where I would go posterior, but still try to remain biological, and I will share some cases with that. And then let's just see from some case examples. I don't do nailing, so I'll just have some shared cases from my colleagues. What do we learn, and what's the way forward with that? So again, as Sergio, I would reiterate what Sergio said. Classical plating for proximal for the shaft of humerus is now an exception than the rule in my book in the last 4 to 5 years, I would say. And that probably lies from the fact that I think humerus, like any other diaphyseal bone, deserves to be treated in a biological way, I think.
Yeah, sure.
There is a controversy regarding still, which is not very clearly answered in the literature, is what about simple fractures? Do they need compression? And I think that is a question that we will debate in the end as we finish this talk. So are we on slide share? No, not yet. Yeah. Okay. So this was a posterior plating. Sometimes the skin incision may be long, but the body inside still can be sufficiently biological. All right. And I think therefore bridging as the principle is probably your go-to technique as long as you can achieve a reduction in stability. This is a question that has always plagued my mind. Is it what about the simpler fractures? Do you need to treat them with compression and you need to reduce them accurately? And if you look up at literature, it's still not very clearly answered. And if as Sergio quoted, the first series of William Belangiero had 50% of fractures as simple fractures, A-type fractures. I think probably the trick in the simpler fractures is to reduce them better. And I think you need to spend some more time in getting a more easier close reduction. Very often it's possible. Sometimes people also do things like an intramedullary Ender's nail or splint, but I think usually you can get away without doing that. This is one of my case with a 5-year follow-up who went on to heal well. I still have not convinced myself yet to put in 2 screws, unlike what Sergio has been trying and telling. And then failures in most humeral shaft fractures from nailing or plating is probably related to not having, as Vivek said, having enough stability at the fracture site, and then secondary instability resulting from inadequate fixation. And that's most often the time the cause is. So very often, as I said rightly, Vivek, if you can achieve the correct stability, the bone grafting is now probably a lesser and lesser need, except in really atrophic non-unions. Again, techniques, everything has a role. So a fracture like this, Sergio, would you do an anterior breech plate in an 86-year-old?
How old is the patient, sir?
86.
How old is the patient? Is 86.
And I'm sure Vivek will nail it, right?
No, I yes and no. Sorry. I would.
So I think
put
Vivek, we will
a
discuss this,
cerclage and
but
a
I
nail.
think more wider the canal distally, I think the nail is a good option. The problem in the
Yes.
younger patients is sometimes the canal is too narrow and you don't have the right size nails that can go in. And
Agreed.
very often, as the case you've shown, sometimes the nails jams at one of the cortex, and that's where it keeps it distracted. That's what you see in those failure cases. So
But can I tell you something?
This is an option that's available. I come to it.
No.
So
just I am
so
sorry
I think I also don't
no.
like to violate the rotator cuff. Yes.
No. I just wanted to
Go
mention.
ahead, Sergio. Go ahead.
I just wanted to mention something that we didn't mention yet, and I have a good experience at which is bridge, long philos plate bridge philos, okay? Long bridge philos. So this is an option.
Yes,
I
yes,
have a nice
that's an
experience,
option.
and this
That,
case is a very good indication for a long bridge philos.
I think the long bridge nail has done a very good job, Dhaval.
it has, it has. So obviously there is always be a balance in every time things may work, may not work. So this is what I think. A lot of the nails also. So for a segmental fracture, nail is an option, but I think very often it's very often the technique that's often at fault when you see failures. Okay, so a well executed nail, as in this case, the nail was too long, not adequately stabilized. The reduction was all right, but so further down the line, when the revision was needed, I probably needed removal of implants and plate. But I think what the surgeon did was a bone graft, and we let that didn't work. And finally, he needed to have a plate to have his listing revised. So we made two fractures, segmental fractures in Europe. With both of them get nails, or you have a plate and a nail.
I would feel that a wide enough
No,
canal
the
here,
case
a
on the
nail.
left has a radial, the distal fracture has a radial nerve palsy pre-op.
In that case, I would just explore the nerve and put in a long enough plate to cover the entire humerus.
Sergio, anterior bridge plate for you
No, 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 no. On
for a
the case on
segmental
the
fracture.
right, no, on the case on the right, this is, it breaks my heart to say, but this is a very good case for an antegrade humeral nail. Very good case, okay? It breaks my heart to say, but it is. But in this case on the right, if this is a good case for a long bridge philos, very good case for a long bridge philos. But on the left, this is a very complex case, a segmental fracture, and I guess that this is a good example for a classical posterior approach. Very good example. Maybe this, I have never used this extra articular AO long posterior plate. This would be a very good indication.
Thank you. So as said rightly, but done in a little different way, is that we use the lateral paratricipital approach to see the nerve. The nerve wasn't entrapped, just got the reduction achieved, and then use the long extraarticular plate in a kind of a breach mode, and did not. So done this way. This is a described technique from the Harbor View group. I think this approach is described. His
Yeah.
radial nerve was intact. The radial nerve recovered in 8 to 12 weeks completely, and he went on to heal well. Against this, as you said, this is good for nailing. The problem with the nailings and what the newer nailings is that I think the newer nailing techniques now takes it away from the rotator cuff, though removal can always be a challenge, as we'll see in a later case. Okay. And this is from one of my colleagues. Okay. So I think what has really probably, Vivek, as you are using more of these newer nails, I think the newer nails go through the humeral head, not nearer to the insertion of the rotator cuff. And therefore, probably, are you saying, or are you feeling that they are more kinder to the cuff or the tendons?
So I think it goes through the bare area. So
they go to the straighter nails.
yes. So
The newer designs, do they not go?
It goes much
The
straighter.
newer the nail
The nail
designs.
follows the intramedullary canal, so the entry point is much straighter, as it's seen in your left picture.
Yeah. However, I think given a choice for a mid shaft fracture, I think the go-to approach for me is as anterior bridge plate. Between the 2 and the 3 screws, I think the issue in my mind is of secondary stability. I don't put lock screws. However, I think in more simpler fractures, I find that the bowstringing from two screws, sometimes the reduction is not, maybe I may not doing the better reduction, and therefore maybe I'm using the 3 screws. But I'm sure if you put the 2 good cortical screws holding well, I think it should do the trick. And sometimes I've seen with when you put 2 screws versus the 3rd screws, how much is the stability changes. But I think it's important to get a better reduction when you do that. As Sergio said, the clinical function is before the radiological picture. Okay. So this gentleman had this X-ray. He was already, he was quite well and doing well. He was a milkman using his hands and actively around. This was a gentleman with head injury, with spasticity, whose physiotherapist somehow landed up breaking his humerus while doing overzealous manipulation. I did something that I would not do, but I was like, what I said was I wanted little more stability because he was going to go back to his physiotherapy. So this is a little different principle use. However, obviously it does not, it heals with, this is still a relative stability. And that's him back as his rehab as early in the line. So the purpose of offering him surgery was cast would have been difficult. He was needed to be back to his rehab protocol that he was undergoing. Vivek, as we say about classical plating, I feel that what we call as this zone of injury around even transverse fractures, there is still a lot of area of comminution that's not very often seen. And sometimes when you put up screws, you land up creating micro gaps because of the incipient comminution that we don't see. Has been your observation when some of these fractures start to throw gaps early, even with the classical compression plating?
Yes, yes. You see the gap increasing, and over a period of time, slowly, if your stability is good enough, that gap closes or by 3 to 4 months.
So
But
revision sometimes can be a mega job, as you see. You will need in order to, if it's a long standing non-union with this thing. This is one of my. And then the same principle, I think, also goes with nailing. The challenge with nailing is if procedure extracting some of these nails can be a challenge. Okay. It may also mean 2 approaches or 2 positions sometimes. So if you want to do a classical posterior plate, you probably have to find, take out the implants and then go on to putting a different position, or the anterior lateral approach. What does the evidence say? We still talk about bracing for humeral shaft fractures, and I think a lot of us would give that informed decisions to patients. Vivek, is that in your book still as an option to offer to patients?
yes, so
Maybe I think the cast may
our
not be a great
patients.
option in countries where there is a lot of heat, moisture, humidity. Sergio, in your do yes.
No, did you ask me anything? Because I didn't listen properly.
So, Dhaval, I think what happens is most of our patients
So
are office goers.
is still in today's 26 still
And therefore they
yes.
want to go back to their work
And
at the
therefore they cannot
earliest.
afford to have cast for too long. A lot of the times,
Yes. So they are told that non-operative treatment works.
Sergio, in
However, they want to
your
get back to work
practice
faster.
No, can you ask me again? Can you please ask me again, because your internet was not stable. So can you ask me again, please?
Sergio, in your practice, do you still have an option to offer non-operative treatment to your patients, or patients don't buy it?
A lovely question. Let me tell you 2 points. First, I think that there will always be a space for conservative management of humeral shaft fractures. There will always be. Point 1. Point 2. I think no. I am absolutely sure that conservative management of humeral shaft fracture is very boring, very boring. The patient suffers a lot. The patient has to come every week to the hospital for X-ray control, and still, if the patient is a little bit obese, then it becomes a mess. So there is a space for that, but considering that we have less invasive methods, the space for conservative management, I am being very honest, the space for conservative management of humeral shaft fractures is diminishing in the modern world. Is diminishing. It will always be there, but it's diminishing. And I guess you guys agree with me. I guess.
I think between minimal invasive plate osteosynthesis and nailing, I think probably evidence probably supports minimal invasive plate osteosynthesis. I still don't have evidence to show good shoulder function or shoulder function in a good humeral nailing series, but I don't have the experience to defend it. That's why I'll be wrong. Vivek could say that in the end. I think for simpler fractures also, I think probably again the evidence still some would say that if you done well, a minimal invasive plating would be better. I think the problem with simpler fractures is you need to reduce them better. That's what I feel. And the complication rates are probably lesser in minimal invasive plate osteosynthesis. And finally, between nailing and plating, I think that's the final evidence that there is probably a little higher incidence of iatrogenic nerve injuries. The healing times are similar. I think it's probably surgeon dependent, technique dependent. So this was a humerus nailing. I don't have his pre-op X-rays. He was a humerus nailing, 10 months not united. Extraction of the nail was a big challenge. Then did a posterior plating by the posterior lateral approach. Went on to heal. Shoulder functions, fortunately, was intact at the end. So I think between the evidence still, I think you need still better evidence to support one versus the other. But I think more surgeons preferred plates. And I think mastering a technique is very important. I think the anterior breech plate, as I said, is a technique. I think it's technique that you probably have to follow to the T. And I think it's still the go-to technique. It works well. And I think humerus does deserve to be treated more biological, I feel. Thank you.
Yes.
Thank you very much, sir. Just checking if there are any questions on our YouTube channel. I think overall, most of the questions have been answered. I think most of the debates that we decided we would cover, Dr. Desai, we have alluded to, nailing versus plating, debates regarding nerve injuries, junctional fractures, and the anterior bridge plating. We have other people on the thing. Dr. Gaurav Sharma is our webmaster. He's a shoulder surgeon. Jayesh, do you have any questions?
No, I don't.
Okay. Excellent.
Mr. Gaurav, here, no questions here as well.
Okay. Thank you. So I think it's been a good 2 hours of discussion, and this was the last webinar of this academic year. We'll be back with some more. And before we finish, I would just hand over to Dr. Jayesh Baviskar to just give a vote of thanks. And of course, Sergio, Dr. Jayesh Baviskar is the organizing secretary of the next year's annual conference. So he will make a plea for, inviting all our members for the conference. And of course, we will invite you as well. Jayesh?
Yeah. Thank you very much, everyone. It was a very, very interesting and a good learning experience. Bridge plating is something which I had heard of, but actually for the first time, I'm seeing good results, looking at the technique, understanding the technique, because as you said, the question lies, the point lies in the mastery of the technique. The 3 points that you alluded, that is the most important step. So the two most important points in the step was the tightening of the screws as well as maintaining the traction. I would also like to take this opportunity to invite everyone for uh, our annual conference, which is YROC, which is going to be held on the 25th, 26th, and 27th of December at the Grand Hyatt. And our theme this time is practice changing guidelines. And probably I think anterior bridge plating is one such thing which is definitely going to be the way of the future, is from what I can see now. So thank you very much, everyone, and have a nice
I
Sunday.
think ABP is definitely a practice changing guideline. I would agree with that.
Yes, sir.
ये पिक्चर अभी बाकी है.
Yes.
When you see the failures of a bridge plating, you'll have to revisit.
Okay.
Can I say something? Can I say something?
Sure, sir. Sure, sir.
Dr. Jayesh Baviskar.
Yes, sir.
I've been struggling to help my Indian friends for 16 years. Finally, I have reached you. 16. It was not yesterday, but I will not give up. Okay, I will not give up. I will still convince you of doing this for the sake of the Indian population. Don't worry.
Oh, thank you very much, sir.
Anyavad.
Thank you very much, sir.
Thank you. Thank
also,
you.
thank you to our two webmasters, Gaurav and Agnivesh, for sticking around. Thank you to Rishi from Ortho TV and our pharma sponsors, Torrent. And finally, a thank to Dr. Ashok Sharma and Dr. Neeraj Bijlani, who have very graciously let us use their services for these webinars. Thank you very much, everything. And Rishi, you can stop the transmission.
Thank you.
Can I say just one more thing to Dr.